Well, welcome audience back to this, our part 2 of our COVID and equity panel, and indeed the final session, save but for some closing remarks, of this year's Nebraska Health Equity Conference. So if you were with us in the previous session, you, as I, took in the thoughtful insights and stories of our first round of panelists, where we ask our panelists to focus on family, community, their lives in their communities. Now in our second part of the panel, we thought we would try and switch gears a little bit and ask our panel members to talk with us about the experiences of COVID from a population perspective, a systems perspective, a data perspective. Yet all the while still looking forward to hearing from our panelists their authentic own voices about the work that you have been doing and what you have been experiencing. So let's carry on. I will note for those of you perhaps following the agenda that unfortunately one of our afternoon panel members, Maria Cantu-Hines, is unavailable to join us. So regrettably, we miss Maria, but we'll certainly carry on and look forward to hearing from our panelists. Once again, audience members, please use the chat box for your response and reflections and questions. We appreciate those and hope to have time, of course, for discussion with you before we end at 3:30. Well, panelists, let's go. Thank you so much for being with us. And let's please first hear your name, where you live, tell us something about yourselves, and talk about the community that you live in and that you work with. Let me see. Mona, please start off with us.
Well, just in case, I suppose if someone missed the last session, I'm still Mona. I'm the Winnebago Public Health Administrator for the Winnebago Public Health Department. We have about 15 field health programs that primarily serve the tribal members that live in Winnebago as well as the surrounding areas. And I do live and work in Winnebago. Let's see, I am a part-time EMT, a full-time PhD student, a full-time mother and companion. And in my spare time, I love to sew and bead. And now I will turn it back over to you, Kathy.
Wonderful. Welcome to having you share with us again from your perspective as a tribal health director. Next, please, Armando, welcome.
Thank you very much. Good afternoon, everyone. And thank you for the opportunity to be here. I want to thank the opportunity also. I want to express my gratitude to the organizers of this event, to the University of Nebraska, to the Nebraska Department of Health and Human Services. Thank you for allowing me to be here with this wonderful panel. It is very humbling after hearing all these anecdotes and experiences from the other panelists. So I am Armando De Alba Rosales. I'm an immigrant from Mexico, and I have the wonderful opportunity and honor to work with the University of Nebraska Medical Center. I am the Assistant Dean for Diversity, Equity, and Inclusion at the College of Medicine, and also a primary care provider from the Family Medicine Department. So it is an honor for me to be here. And I also want to express my gratitude and a permission to the indigenous communities that intersect in this great and wonderful state of Nebraska. Thank you very much. And I look forward to this presentation.
Thank you. Thank you, Armando. John.
This is great company, and I can only hope to live up to Mona and Armando there. My name is John Figliomeni. I am with the Department of Health and Human Services here in Nebraska. I am currently the Public Health Lab Surveillance Coordinator, helping to organize the various public health lab surveillance programs, biological, chemical programming throughout the state. Prior to that, I was actually working on drug overdose prevention, also with Department of Health and Human Services. I am a recent transplant to Nebraska, originally growing up in Michigan. So this is a little bit of a different culture. There are decidedly fewer trees here than I am used to. So I'm getting used to the Plain State and learning to enjoy it.
Great. Thank you, John. Welcome, welcome panelists, and thank you so much for joining us for this discussion. So I think I'm just going to get right to the note that we'd like to hear about disparities. So the way we framed this question is to say, in your scope of work, in the data that you work with, what can you tell us about the disparities you have seen in how COVID has affected people in Nebraska? First, John, would you care to just go ahead and talk with us about that?
Certainly. If we kind of look back to the original incidents in the state of Nebraska, going back almost to February and March of 2020, we began noticing that some of the first big flare-ups were in long-term care facilities. The public health lab and largely the state in general were reactive in a lot of this and trying to respond to what were often seen as the most vulnerable populations. Again, long-term care facilities initially, and then it began to spread largely out of control. Prevention measures were very difficult to come by early on, getting into June and July even. Thankfully, the state of Nebraska, Governor Ricketts there did look for other options for testing to help us identify the cases throughout the state here, at which point testing became almost universally available. It was truly one of the wonderful things that happened early on in the pandemic. At that point, the public health lab was able to transition away from broad surveillance to underserved communities, including the tribal communities, including some of our FQHCs throughout the state. Obviously, Omaha and Lincoln, being the population centers, were where we were able to position most of our supplies, but we made it a point to keep capacity, to keep as much of this open as possible for underserved communities throughout the state. Rural Nebraska, again, tribal communities. We made a lot of inroads with the Great Plains Tribal Epi Council as well. We reached out to them as soon as we were able to, and basically sat down and said, look, we have resources. What do you need, and what can we do to help? We've been able to actually exceed some of the statewide representation at the public health lab, mostly by offering help and listening to what communities needed, whether they needed additional testing capacity, whether they needed trained professionals, whether they needed explanations. But the most important thing that we have been able to do is to stop and listen and just say, we have resources. Please, what do you need?
John, I wonder, before we go on, if you just might add a quick comment or two. How did those connections happen between those groups that perhaps had those additional needs for testing? I'm just curious about, how did those points connect?
As I mentioned, I actually worked in drug overdose prevention before COVID began, and at the time that COVID was beginning and the public health lab needed some coordination and better communication between the state and the public health lab, I was able to kind of roll off of opioids and leave that program to a number of other people at the state. The year prior, I had worked closely with the Great Plains Tribal Epi Council for drug overdose prevention. So at some point, it was sitting down with the digital Rolodex and saying, who else is out there that I know that we're not traditionally seeing here in the lab?
Super. Thank you. Thank you so much just for talking about that a little bit more. Let's go on. So Armando, you're next. Talk about the disparities you have seen through your work, the ones that you would like to lift up for us, please.
I think I need to unmute my microphone. Absolutely. Well, first I would like to start with, what do we know now? So we now understand enough about the epidemiology of COVID-19, right? We have heard a lot of terms, new terms, efficacy, if there is something that, flattening the curve, etc. So we now know about all these terms. So we also know how to effectively limit community spread, wearing masks, washing hands, keeping a physical distance, how to provide effective supportive care for the majority of patients with severe illness. And we also know in the sickest patients, we know that at the end of the stage, when we have this disease, the COVID-19 is more because of the inflammatory response more than the viral replication. And also we understand who is at greater risk. But most importantly, we also know that the virus does not have a preference for a particular race or ethnic group. In other words, I want to share actually a statement from one of my colleagues, Dr. Jasmine Marcelin. I like her statement that she said, the virus is not racist, but the individuals and the systems can be. And in order to get there, we need to actually define what is racism. And I like the definition from Dr. Cameron Jones, because it is important that we actually present this dimension and this perspective. Racism is a system of structuring opportunities and assigning value based on the social interpretation on how one looks. And that is something that has impacted our communities, our minorities communities. And let's recognize that what we're experiencing and seeing is nothing new. It's been a historical a problem. And with COVID-19, it's been just exposed more than probably in the past. So even people like Dr. Fauci has stressed that the most pervasive disparities are observed among African-American, Latino individuals, and where that exists among American Indians, Alaska Native, and Pacific Islander populations. It's been presented at the national level and by these reference and scientists in our nation. We know as of April of 11, 2021, which is when I last looked for this specific information, that in Nebraska, around 400,000 individuals have been fully vaccinated against COVID-19. However, of those fully vaccinated, 90% were white and 4.8 were Latinos. And also it's very similar with other underrepresented minority groups. COVID-19 is a health disparity. It's actually a multifactorial issue. We will take days to talk about, the different challenges that we have, and related to the question that you asked me about health communication, and that is actually an area where I am most involved with the COVID-19. I have had the honor and privilege to assist the University of Nebraska as a spokesperson actually since February 2020. And I want to share actually from a personal perspective. I'm going to remove institutional hats. I became involved because I raised a hand. I actually approached one of my professors from epidemiology who was involved in the initial very early responses of the COVID, of this emergency response. When we were first receiving the patients from the Princess Diamond cruise from Japan, actually in the early stages last year. And I approached this professor. I said, I would like to participate. I would like to join the efforts because we are building all this response, but I want to make sure that at least the community that I'm connected with, which is by nature the Latino community, that's where I'm coming from. I said, I want to make sure that that community is also being informed and maybe collaborate and see how other minority communities are also being connected with these efforts. So back in those days, when I looked around the room of that emergency operation back in February, it was wonderful. I would say a lot of experienced people who I am very grateful and I have learned a lot from and passionate about what they do. They were actually organized by different sections. There were people from the CDC at the federal level. There were people from the National Public Health Services. There were people from the emergency response from UNMC, people from the media, the experts about media. But when I look around the room, I couldn't identify minority leaders there. That is where I say, well, what, and that is actually something that I'm happy to explain, to talk later, and present it as some of the things that maybe we could do. But
Right.
I guess my message here is we need more diversity at the leadership level in order to actually bring everybody on board at the same time.
Right.
I will stop there just for the sake of the timing.
Oh, yes. Thank you, Armando. Well done. So much good information. Mona, our topic is about what disparities look like to you through your role. Please, won't you tell us a little bit more about your experiences with COVID?
So, oh, excuse me. We have the ability to collect and analyze, store our own data. So from the first case we announced back in April of last year, we were able to publish on our Facebook page and web page, but we only didn't use just this platform. We put flyers in the lunches of our senior citizens' meals. We put it in the lunches of our kids when there's all these curbside pickups. Because our audience is so diverse, we had to even put like posters in all of the mailboxes downtown because we are a small community. So we presented and used the data to show the people where our people were getting COVID from and the age group. And we also have connectivity problems here in Winnebago, and I'm sure we're not the only rural area. So we weren't always able to keep those connections at time and keep people informed. So we did the best that we could through, other measures like those flyers and Facebook pages. And another issue that we kind of had was that we don't have access to the state system. So we get our labs approved in the beginning at one point by calling the county health department. Of course, we work very closely with the county health department and we have a great partnership, but that was just one more piece that we had to, or one more barrier that we had to overcome instead of just telling our lab, yep, it sounds like someone that should be tested, because we had our own tests. So basically it was just being able to send them to the lab, but we had to make sure that we got it approved from our county health department. Another issue that we've seen was that, we shouldn't have these discussions during a pandemic. We should have these discussions, starting now on how we can work within the system, because we shouldn't have to wait to get our tests sent out. We should be able to receive those reports directly to us. We shouldn't have to go through the county because we are our own local health department and we have the same public health authority, if not more, than the county health department.
Oh, yeah.
So I think that's important because, as I think Chairman Larry said yesterday, that we know where our aunties and uncles are staying, our cousins and relatives, and sometimes they're in Lincoln, sometimes they're in Winnebago, sometimes they're in Santee, but we always know where they are. So even though their address might say they live in Sioux City, they might live in Lincoln, we know that they're living in our town. And so that's important for us to get that information back. So being able to make those connections are just vital for us to be able to put people into quarantine or isolation, be able to respond to their needs immediately, instead of having to wait those hoops in order for us to provide good continuity of care for our people.
Wow. Panelists, all three of you, such insightful remarks in response to the prompt. Well done. Let's carry on. So this next question, I will just read and turn to you to answer. John, you'll be first. Based on your experiences, what are your thoughts about ways that data collection and reporting and communication might change in order to better meet the needs of disadvantaged groups in the future? any insights to share with us about how might our data systems continue to develop more to serve equity? Go ahead.
On the broadest of scales, I think Armando said it maybe most eloquently here. We need to think on a larger system for how this all works. There's a broader landscape than just public health. Yes, health happens in a hospital. Health happens by meeting with your neighbors. There is a much broader and much more interconnected landscape than what we're really looking at. We can't expect sufficient data collection by asking people to take time out of their day when, unfortunately, time is money. And if someone cannot break away from work or needs to take care of children or whatever the case might be, might need to worry about catching public transportation to get to work or to home to handle children, it becomes incredibly difficult, and you start to lose the most disadvantaged and underserved populations. Looking at the whole system and why it's not working for disadvantaged groups, why it's not working for underserved populations, you're going to be able to find answers instead of just symptoms to problems here. I think one of the better anecdotes that I've heard was some study as far as life expectancy. I believe it was in Thailand a number of years ago, but a toaster was the single greatest predictor of life expectancy in, again, it was Thailand or something to that effect. And that's because if you own a toaster, you are probably wealthy enough to take care of your health in some way, and you don't need to worry about scraping by. The toaster is hiding something. It's a symptom of something greater. And that's what we need to start looking at. We need to start marrying vastly different data sets to understand our populations better than such and such a minority has lesser outcomes for health procedures than another population, and that certainly is true, but it's hiding behind something much bigger than that.
Gosh, well done. Thank you, John. Mona, do you have thoughts for us? You kind of alluded to how you're caught in these cycles that result in data perhaps not getting to you effectively. Please go ahead and talk with us a little bit about how you would like to see data systems change.
I think when I hear you say this, I think of data sovereignty, which is the utmost importance to many tribal nations. In essence, excuse me, information, data, and research about our people collected about us, with us, or by us belongs to us and must be cared for by us, the Indigenous nation. Indigenous data sovereignty is the right of a nation to govern the collection, ownership, and application of its own data. It derives from the tribe's inherent right to govern their people, the land, and the resources. So I think it's very important to build capacity within the communities themselves, so we do not have to rely on the state or the federal data to be able to come down to us, is to build capacity within our own communities to be able to provide that. So right now we're working on that fragmentation on how we collect, but we're getting better. We don't always communicate maybe in a very effective way between each other, between the state and the tribes, but we must look through that Indigenous lens. It's important that we do not come from a deficit approach, but a strength-based approach within our communities. We have many things that are working well within our communities, and it's important that we capitalize on those, looking at that data to strengthen those approaches.
Wonderful. Thank you. Thank you so much. Armando, over to you. What might be your reflections on how data collection might be done better to serve equity?
Absolutely. And actually it makes me think, I don't want to be repetitive. The whole comments cover really good the perspective, my initial perspective, or the comment that I wanted to share. However, I want to focus this time on that communication that is important during the pandemic, that we need to do it culturally, linguistically appropriate. In terms of academic, with academic terms, there is actually a definition there, health literacy. Many of you probably are familiar in the audience. And the health literacy, the traditional way, used to put a lot of weight on the population, on the patients, on the community about how well they understand the information. However, we need to recognize how well we communicate as healthcare providers, as healthcare services, in order to make that connection and work that communication, make that effective communication. So from that lenses, I want to basically present two questions to the audience and leave it to the table. Basically, one, it's who benefits from the efforts that we're building, and two, who are developing the solutions. And it goes back again, who are we bringing to the table? And those who are in the table, look around, who are we missing in order not only just to build that communication or the written information, not only just to communicate in front of the media or by television, but also who are on the decision levels at the authority level to actually coordinate an efforts and recruit minorities, recruit leaders. And because if you actually bring diversity at the leadership table, you will be able to also bring resources and protect time. A lot of the times, and actually Ms. Dori Lassiter presented or shared that a lot of her work is voluntary, she does it in a voluntary basis. I'm sure many of us here, and especially those who are minority, from minority populations, including myself, we have to volunteer a lot of the times. And sometimes we are doing this in our free time because there is not a system that protects our time from our work. We have the privilege sometimes to work for an institution, but a lot of the times we're not protected. How can we make the system protect minorities who are doctors, who are nurses, who are working in institutions? Well, by bringing diversity at the leadership table, by looking who you are funding. And this is probably a message to the organizations. If you have opportunities for funding research or research opportunities or interventions with the community, look at who are the principal investigators. Look at how many principal investigators from underrepresented minorities you are providing the resources. Look who are those research projects who are bringing the community together and are offering also opportunities for work, not only just to delegate responsibilities, but creating jobs for minorities who would like to participate in these efforts. Protect them. Those who are in the leadership table have a lot of power to protect those minorities and also distribute the resources equally and fairly.
Terrific. Thank you, Armando. Thank you, panel, for your thoughtful preparation, your readiness to answer that question, and each with such distinct and powerful responses. What I'd like to do, panelists, is suggest that we'll tackle one more question together, maybe 5, maybe 6 or 7 minutes together, but then we'll go to questions. I think we might have some interaction from our audience and we don't want to miss it. So in this question, panelists, as with our first session, we'd like to pose to you, what is a lesson you think COVID has taught us about equity and justice? Mona, would you like to begin?
Sure. I think COVID has, my goodness, I'm sorry, I must have been talking too much today. COVID has elevated the discussion about health equity for our people. Health equity means that we're on the same plane, but we're not. COVID has shown our people that there are still people that do not have running water today. We still do not have adequate housing today in the United States. Some of our tribes are in a better situation than others, but we cannot reach equity until all of our people are in a better situation. When we hear on the news through Facebook or wherever, because Indian country is small, you get your news that a tribal nation is losing members. We're all affected. Each tribal member is, regardless of their tribal nation, is precious. They are the cultural and traditional knowledge holders and keepers. And we are all relatives. We come from all directions. Some of the tribal nations look at that medicine wheel, and that is a representation of all nations from all directions. So perhaps we need to draw upon those diversities working together, because we can only prosper if we're all moving in that same direction.
Very, very fine. Thank you, Mona. Armando, what would you like to share? A lesson on justice and equity.
Absolutely. First, recognize that disparities exist. That's one of the first steps that I would like to recommend. And one of the lessons learned from this pandemic, we need to recognize at the different levels that disparities exist. Center or work with equity lenses that intentionally recognize and address root causes of structural inequities. Representation in the leadership and decision tables, representation also in our healthcare workforce. And I'm gonna also recommend at our institutions, especially those who are building the new generations of the healthcare workforce, to open doors to look at how can we increase diversity among our students. How can we connect those future generations who desire, those kids, those children who desire to be doctors? There are children who want to be doctors, nurses, technicians. Why are not reflecting that desire in the diversity of our population within our institutions? We need to find the solutions, identify why is this happening, and open doors to those generations, because that is the way how we're gonna be ready for the next pandemic. That's that's one of the main solutions how I see. We will make it more sustainable and more solid, our healthcare system. And diversity drives excellence.
Mm-hmm.
And also build solutions with the community and let them lead efforts.
Mm-hmm.
Thank you.
Wonderful. Thank you, Armando. John, your remarks on lessons learned.
I think the biggest lesson that I have been able to find throughout all of this is that the answers to public health problems are not strictly found in the public health field. I come from a mathematics background, and there is an axiom in there, the incompleteness axiom, which effectively says you cannot know all of the boundaries of one field of mathematics by looking in that one field. And this is exactly what we're finding out as a result of this pandemic. We are not going to public health our way out of all of the public health problems. We need economists involved in public health. We need labor. We need revenue. We need a much broader selection of disciplines in the same way that we need a much broader selection of peoples at the table. The more people, the more diverse the voices, the more diverse experiences and knowledge that you have at the table, the more robust a solution that you can create. It's not necessarily a one-size-fits-all because you have a well-selected group of people at the table, but it's one that you can bring to each community and they can say, there's a piece of me in that. I can make this work for my community. I can do most of what you're saying and I can make it functional for my community.
Thank you. Thank you, John. Panelists, you've done a wonderful job. My sincere thanks to you for how mindful you've been of the time as well as the richness of your remarks. We all are doing this work together. On behalf of the Planning Committee and the audience as well, panelists, thank you so sincerely and so humbly for the way that you have shared and informed us today.